Great. Welcome, everyone. Good afternoon. My name is Cynthia Klein, and I'd like to welcome you to today's session. The title of today's session is Preparing and Understanding Your Data to Support Systems Change. On the next slide, a couple of reminders before we get started. So today we will be embarking on our fourth of 10 training modules. So you guys are almost at the halfway point. As a reminder, all of our materials are based on the Million Hearts Cardiac Rehab Change Package. As you see on the link here, that's located on the Take Heart website. It's in the Resource Center. We've also highlighted a couple of the resources down here that connect directly to the training content. Also as a reminder, the format of these sessions is we start with the training module that we have today. So we have expert panelists available, also a hospital representative who's been in the same shoes that you've been in the past. So those are available for today's discussion. Following today's training, you will see an implementation guide come your way with step-by-step how-to guidance on how to implement these steps. And then followed up by that, you have your peer action groups. These are really important meetings where you're able to meet with your peers and hear a little bit more about how their implementation is going, maybe some of the barriers, some of the challenges, and be able to share support in that way. And then after the session, please know you also have that opportunity to follow up with your coaches at any point. So we're trying to support you in a couple of different ways through these modules, but if you have any questions, always feel free to reach out to a coach. On the next slide, we do look at these training modules to be as interactive as possible, so we'd like to encourage you to use the chat function. You can see here across the screen how to connect to the chat box. We do ask that you set your to field to everyone so that we can all see your question at the same time and see some of the discussion. And then I think my one last announcement is on the next slide. We do offer, CEU credits for these courses. So if that's something that helps you, something you're interested in, please know there'll be an email that follows up after this training, and you can take advantage of that. And I think with that, I'd like to go ahead and pass it over to Steve Hines, who will take us through the content. Thanks.
All right, thanks very much, Cynthia, and good afternoon to everyone, unless you're on the West Coast, in which case it's still good morning. But we're delighted that you've joined us for Module 4. And if you recall in Modules 1 and 2, we talked about the reason why automatic referral and effective care coordination are really important and how you needed to lay the groundwork in order to prepare to implement both of those effectively. Module 3, which we covered last month, talked about workflow processes and the processes that you can use to identify gaps and opportunities to improve the systems for automatic referral and care coordination, including how you process and collect and make sense of the data that you have, which is really foundational to both. Today, what we want to focus on is data. And data is incredibly valuable, and it's also a little bit intimidating to some people. And so we're really hoping that we'll be able to help you understand the value and perhaps lose some of the concerns that some of you might have about making sense of the data that you have. So we want you to understand why it's important and which kinds of data you should be thinking about, the value of establishing baseline rates for some important measures like referrals, enrollment, and whether your people that register for your cardiac rehab program actually continue to attend. And then how to create a data collection plan that will help you as you measure and monitor your performance of changes that you make for the Take Heart project. So that's what we'd like you to be able to accomplish by the end of today. And we asked you as you registered for the event to tell us, to answer a couple questions related to your current uses of data. And so here's the distribution of how people responded to that question. Of the 40 or so people that responded to the questions, about half said you monitor a small number of key metrics like attendance and graduation and referral rates. A third said you regularly look at lots of information to inform your strategic planning and your operations. And if so, that's great. Some of you said, about 10% that you rarely review or make decisions based on data. And then a slightly smaller group said, it's really not a part of my job, so I'm really not sure how we use it. Now, one of the other interesting things that we found on that past slide is that when there were more than one response from the same organization to this question, about a third of the time, the two respondents from the same organization answer that question in the same way. About 2/3 of the time, your answers were different. And it wasn't just somebody saying, I really don't know about data, and somebody else saying, we regularly use it a lot. It was sometimes people saying, we regularly look at lots of information, and somebody else in the same organization saying, we rarely review or make decisions based on data. So one of the things that we really want Take Heart to do for you and your teams is to encourage you to learn from each other and improve your internal information sharing processes so you can really maximize the value of the data that you have. Now, when we asked about the specific kinds of data you had access to, and people could, identify all of these different types of data, assuming that they had access to it, what you see here is the same exact pattern that we saw with the first cohort of practices. So the number of patients that were eligible for cardiac rehab based on admissions to an affiliated hospital or system, that was the type of information that the fewest number of people said that they had access to. You just don't know how many eligible patients you actually have. And that's absolutely foundational to automatic referral. And if you work on getting automatic referral in place, you should be able to raise that number. How many of the eligible patients are referred? Again, if you don't know how many eligible patients you are, figuring out the percentage of those that are referred is going to be tricky as well. About 40% of you said that you had enrollment and graduation numbers grouped by sex, age, and other demographics. And that's really good to see because there are some underrepresented populations like women, persons of color, persons that are economically disadvantaged, and understanding how their participation and attendance compares to that of other groups is really important for you to know what sorts of interventions you may need to do to help those patients more. And then once you actually got people enrolled, then information on how many sessions they attended and how many people attended at least one. Most of you have that, which is great to see. So that's what we learned from you. Now, it doesn't matter whether you where you fall with respect to these the kinds of data that you have at present or how you use data in your program. There's a good starting place for all of you, and today we want to help you move along towards that. So what I want to do now is to introduce the two panelists who we're going to be listening to. Sherry Grace, a professor at York University with incredible insights on cardiac rehab, and has done a lot of research and work to do a lot of things to leverage data to enhance participation by underrepresented groups. And then Matt Thomas, who participated in a range of Take Heart activities and is the director of cardiopulmonary rehabilitation at Keim Memorial in Chattanooga. They have some great stories to tell, and at this point, we'll turn it over to them. I do want to emphasize, though, we have the chat function, and throughout, as they're making a comment, don't wait till the Q&A session at the end. If you have a question or a comment or an observation or something else that you use when you work with data that you want to share with the group, by all means, put that into chat. And then at the end, after we've listened to Sherry and Matt, we will revisit the comments in the chat and additional questions or comments that you provide towards the end. So at this point, we'll hear from Sherry and Matt.
Yeah, so thanks so much, Steve, and it's a pleasure to be here with everyone. So data can be a bit daunting, so I think we're here to help everyone keep it in perspective and see the great value of using the data that you do have available. So it's very important to us because in quality improvement, it really helps us assess where we are at to start with. And then from there, we can see the gaps, any errors in the data, any discrepancies between where we are, where we want to go. And then it really enables you to set kind of realistic targets about where you want to go to over time. For the Take Heart project specifically, we're using data to implement a workable automatic referral system for inpatients, exploiting EMR, and as well as this care coordination, so promoting our patients and enrolling, adhering, and completing programs. So data helps to establish the need for the Take Heart project, so you can communicate that to your stakeholders. You can say, hey, this is where we need to be, and this is where we are today. You talked about your workflow process improvements last module. So this helps you kind of see where you're at in relation to those and where you want to go. It helps you monitor your progress. So as you move along, and it helps you ensure that as you change, that you can sustain it over time. And it's really difficult to refute if you have data. Those on your team, those stakeholders, hospital leadership, are really going to listen, and it's going to be compelling to them. So there are kind of different ways that you can use data. When you get data from a patient chart, which you'll be doing from an individual patient, you could look at things like diagnosis or their indication, did they have a CABG? Why are we sending them to rehab? What's their age? What's their sex? Where do they live? What is their rehab use? So we can get all that at the patient level, and that helps us tell some things. But then also, if we aggregate it, we can look at kind of overall measures or indicators of how we're doing. We can generate reports to look at. So, overall, get a sense of, in your population of patients who should go to rehab, how many of them are eligible? Of those, how many are referred? How many enroll? We can also look at underrepresented groups with some of that patient level data that you gathered. So here are some kind of examples of how you can use the data if you have the patient level or this aggregate data. So at the patient level, you can kind of look closely at, which patient, why was that patient not referred, for example, or, is that patient from an underrepresented group, and so maybe we're not engaging them as we could, or there's certain providers that don't seem to refer. Maybe you can talk to that provider about a reason, that they might not have when you don't see one. But at the aggregate level, you can take a look at your workflow processes overall. You can take a look at the proportion of patients that you're actually getting in relation to your target, etc. So last time, you've also kind of got a sense of the team that you need. And so again, you want to gather all those people around to work with you and make you successful. So definitely you need the acute care team. So we're, referring from that inpatient unit, but you also need the rehab program, right? So you have the full continuum of care. You're going to engage the clinical and the non-clinical staff involved in the referrals and the care coordination, right? You need to know what patients we're trying to get. And then you're going to have your partners in kind of IT, billing, coding, who, really have a lot of the data and help you understand the data, access the data, and hopefully you might have quality improvement representatives at your institution or data analytics even, who can help you around kind of the process improvements and visualizing the data and tracking, etc. So the goal here is to collect your baseline data. So for the automatic referral piece, right? So we first need to know where we're starting from. So before we make any changes, we need to know this is where I am. And so basically you want to get a sense of, from your institution in your inpatient unit, how many eligible patients are there? So what is your pool, right? And then of those, how many have been referred? Look at diagnosis. You can look at the providers, right? Are the surgeons referring the same degree as the interventionists, for example? Take a look at the sociodemographics as well. From a care coordination perspective, You can also take a look at some important baseline matters, such as how many patients enrolled, where were they from, looking at their zip code, are they in your area, are they not, were they contacted by a care coordinator, what were their demographics. So your key first step here is, again, to look at that workflow process that you created last month. Use the data planning tool that was provided to you, and then you can work together with this team to gather your baseline data. And I'm going to pass it to Matt now, who will give us some examples on how he did this.
Yeah, thank you, Professor Grace. So, Professor Grace has gone through a lot already of different reports that you can set up and that you can potentially use. And I think one thing that we all need to remember is that our data is going to be unique to our center. So if we think a little bit about how we set our baseline, we need to recognize that this is going to be, in large part, an individualized process. What are your current needs? And I think a good place to start with the baselines, and at least this is how I typically approach it, is to first start with what are your expectations. And what I mean by that is, what do you expect to see in any particular value? So do you expect that you have a good conversion rate? Do you think that it's high? Well, expecting that to be true, and conversion, of course, I mean, getting your referrals and turning them into participation. You can expect that it's good, expect that it's high, but that's not always the case. So turning it into the observed is very different. And that's where data comes in. The baselines become really very important because, as Professor Grace already pointed out, this is how you show value to your team, to yourself, to your patients, your administration, etc. It really becomes the objective measure by which you're able to perform, set action plans, and move forward. So it is certainly worth your time. So you have to start by discovering your baseline. And as I'm kind of pointing out, you have to first decide what's the most important thing for you to look at. So here's some examples, right? And these are just kind of things that we look at typically in our centers, things that we track routinely. One of the reports that Professor Grace mentioned was your referral source report. Well, this tells you a lot about who your main providers are, who your referral sources are. Are they coming from inpatient settings, outpatient settings? Are they from your surgeon, your surgical team, your interventional cardiologist, maybe your non-interventionals? And being able to discover who those providers are and how they're referring tells you a lot about how to leverage your successes and also be able to identify the areas where you're deficient. And I think really with the baseline information, the main thing I typically look for, and not that I'm trying to celebrate our shortcomings or failures in our department, but it provides opportunity. When you have that baseline set, you know what's abnormal, you know what is off of the mark, and I think that this is a good analogy for our cardiac rehab world. It's how we do EKG each and every day, right? We start by knowing what the baseline is and what is normal sinus rhythm. If something's different from there, we start to ask those standard questions of why. We can get analytical. The same is true with all of our data metrics. Once we know our baseline, we can start to move through some systematic questions that are going to be able to move us forward on a good action plan as we interpret the data. So looking at your referral sources, looking at your referral profile, for example, let's say that you have 10 cardiologists, but you go through and start to look at your data and realize only 3 or 4 of them are referring. Well, that provides you some opportunity, and you can start to set an action plan in place. Baselines can help you identify who your main primary participant is. This is some real life data I pulled for this talk. We know from multiple cross-sectional analyses over several years of operation that our standardized patient is a 68-year-old Caucasian male with a history of an open heart or a CABG. That isn't necessarily just so that we can know who our patient profile is. It's so that we can see now who are our uncommon participations. How can we reach out to them? How can we leverage those successes again, but identify those areas that we're deficient? So once you've set your baselines, you really want to spend some time asking some analytical questions. Analyzing the reports, asking the questions is a big piece. And I think a big part of this is if we're talking about the expected versus the observed, right? make sure that it's not just your own expectations. Bring those expectations to your team. Our own expectations certainly can provide some bias. So if you look at the expected numbers or values and you talk to your team about that, see if they match up. Then once you get your observed data, really bring it back. And if the observed is vastly different, now you can start to ask some questions. Why? Do you have good methods of collecting data? Or is there a potential source of data that you're missing? Are you over-reporting? Are you entering bias because you want things to be successful? Those sorts of things. So just make sure that your expectations are also meeting your teams. And in valuable settings like this, where you're able to interact with your peer, do your best to benchmark against other sites so that you can really kind of check the reality, so to speak. And Professor Grace is going to take us through a few other baseline considerations.
That was really helpful. Thanks, Matt. Thanks for sharing. So yeah, we've got now this baseline data. Now we want to manage all these eligible patients, track them along, measure what's going on as we implement our workflow process changes. So what do we need to think about? We need to think about our new processes required. What is your plan for the increase in referrals that you're going to get? So at the rehab program, how are you going to absorb these extra referrals without expanding your wait time? What additional resources are required? What software do you need? Who's going to handle the monitoring and the reporting? How are you going to fill those roles? And then what about missing data, right? So you can't get everything that you need at once, but what the most important pieces are for you and your team, there's going to be some missing. Can you get that? When will you do this, right? So getting everybody on side for kind of when it's going to get started, and that's kind of one of the keys to success. So once we have, again, this baseline and we have this plan to track everybody, we really want to see the change and take a look at what our actions and our workflow changes, what happens as a result. So this helps us kind of inform decisions over time. It helps the team understand kind of what's working based on what you're doing, what are the impacts of your efforts. And then you can communicate that through your organization, and that can continually drive more improvement and more improvement. And that really also maintains accountability, and it helps with sustainability too. So let's now take a look at a couple tangible measures, and you will recognize these from AACVPR. So a measure generally has a numerator and a denominator, so we're just doing some simple division. You can do this in Excel, for example, if we want to keep things simple. But for the automatic referral piece, the most important measure is the percentage of patients referred. So your numerator generally is the number of eligible inpatients referred. And the denominator would be the number of inpatients discharged with the codes, the ICD-10 codes. And again, those are all listed in the materials in the implementation guide. And are well established based on evidence. I would say you might want to consider some exclusions and kind of talk about those with your team ahead of time so everyone's on the same page, because they can vary based on your program and your institution. So we did a consensus process internationally, and some of the exclusions that we consider to be valid are things like advanced terminal illness. So maybe a cancer patient in palliation, some sensory impairments, so maybe extremely low vision, serious mental illness. So I wouldn't say depressive symptoms, anxiety symptoms. Those are very common, and those are ameliorated in rehab, as we know. But patients that, for example, have uncontrolled schizophrenia or substance dependence, that's going to impact their ability to participate. So those are some kind of valid exclusions, and again, talking maybe to the inpatient referring providers about those, and again, getting consensus would be helpful. But again, then you have to be able to kind of think about how you'll capture those, or maybe you can even capture, are any of those exclusions applicable to this patient, yes or no, if you can't get that sophisticated yet about measuring some of these specifics. But again, I think it's important to have a dialogue, because this is a pretty important measure. And then when we look at care coordination, enrollment is the main indicator or measure there. And by enrollment, we mean generally attending a first visit at the rehab program. So here the numerator would be the number of referred inpatients that came to that first visit. And then the denominator would be the number of inpatient referrals you have. So again, here just focusing on the inpatients only. You don't want to maybe include any external referrals to keep things clean. And here, again, you might have some exclusions that you might want to get consensus on in advance. This might be things such as, you know, a patient says, hey, wait a minute, I'm going out of the country. I'm going to start, can I start in 6 months, right? And if you notice here in the top right, we're suggesting start perhaps with a monthly measure. You can, again, tailor this to your program and your needs. But if you're doing that on a monthly basis, you do maybe want to leave out patients who, or maybe they live in another country and they're not coming back, or maybe they say, you know, I literally do not have any transportation to get there. And, you know, you don't offer a virtual program. So again, talk about some of those. And again, this will be one of your main indicators of care coordination. There are a few other measures.
Professor Grace, before you move on, I just think it would be helpful for the audience to know, as you were like working with the cardiologist to build consensus around those exclusion criteria, how long did that process take? I don't want anyone to think that they can do this over a weekend, but on the other hand, I don't want to think that, not to think that it's going to take forever either. So could you just talk a little bit about how long that took for you to do?
Yeah, so certainly. So I think we did it as a kind of a research community, and I can share that with participants afterwards. We have a Delphi process and kind of came to an agreement, because sometimes I think that inpatient physicians think some things should be exclusions when they aren't really valid exclusions, because they don't know maybe as well what we do manage in rehab and all the different elements of what we offer and how it helps patients. So I think even just having the dialogue is good, because I think you'll circumvent them not referring patients that would be really good candidates. I think that's kind of the benefit of it, is having that dialogue. And again, if we kind of use this evidence around, you know, there's an international consensus that, you know, these are valid exclusions, but these ones maybe not so much. And then I think it's more of a dialogue, and it doesn't need to be, you know, too difficult or onerous for as part of the process.
Thanks.
Yeah, no problem, Steve. So a couple other, I mean, if you want to measure other elements too, on the next slide, we'll see a few more for the referral piece. You might want to measure wait time. So the number of business days from the referral being received at rehab to that patient attending their first visit. And I think sometimes we actually see that wait time going up as we refer more, right? So it is nice to watch this along with your workflow process improvements, because sometimes you can see these unintended consequences and just want to keep an eye on those. The other thing, as we were just talking about, is like looking at some of these exclusion reasons. Are they valid? And then, you know, do you need to maybe tweak your EMR referral system to better deal with this, so that it's easy for everybody and everybody's on board? With regard to the care coordination piece, you might want to also measure the number of patients that have a visit or an interaction with the CR care coordinator, right? So did that interaction happen? And also looking at the patient adherence. We get them in the door. You would prescribe 36 sessions generally. You know, what percentage of those sessions did they attend? Did they go and complete or come to the post-program assessment? So with that, we have a few tips for success here. You know, we can't do it all at once, as Steve mentioned at the beginning. So start small and just expand over time. You want to keep your data collection really simple. You want to think about your highest priority changes, you know, based on that baseline data, as Matt was showing you. You know, think about what is the most important for your center. Measure frequently. So when we're thinking, you know, generally a month at a time is nice, and you can see change that way. Discuss with the team that's working with you. What progress are you making? What success are you making? But then again, there will be some areas where you want to make some improvements, revisit some things, and adjust and try again. So let's pass it over to Matt for some more stories from the field.
Yeah, thank you. So I think I think we tend to approach data sometimes in the wrong way. And we have the misconception that, well, I'm not going to collect particular variables because I'm into patient care. That's why I entered this field in the first place. Data is for my informatics teams and administrators and people who spend all their time in the offices. So it really doesn't resonate with me. It's not something that I have to pay attention to. But I kind of developed this little case study just to show us that data should be part of evaluating and improving our operations all the time. There are times that change is going to happen and we have to react to it. And so again, as I kind of pointed out in the first part of setting those baselines, is that do our expectations meet what we're actually observing? Does the shoe fit, so to speak? So here's a scenario for us to discuss and kind of consider as we look at, and not totally exhausting this subject, but how we would respond to some scenarios that are more than likely in our centers, especially as our programs continue to grow in response to just kind of the trends in the United States right now. So your hospital's cardiology clinic has been given approval to design and open a heart failure clinic in the coming year. Your program's medical director has excitingly told you that they anticipate in heart failure referrals are going to increase, and you're going to have the opportunity to get referrals from the community, so primary care providers, rather than just your typical inpatient pathways. So in preparation for this, your service line administrator has asked you to set up an action plan on how your cardiac rehab program is going to be able to accommodate what you anticipate to be a growth opportunity. So here we have it, just perfect scenario, falls in your lap. Your cardiology service line is growing. The downstream is going to fall into cardiac rehab. What are you going to do next? So let's look a little bit about at this case study and see in what we find when we examine the data. So we've picked our variables. We have looked at, what we expect to be our main baselines, what we think we know, what we expect, and we even dial it down and look at what we observed. So in examining our data, we've seen that heart failure diagnoses at present only make up about 15% of our total referrals. Heart failure participation is low. So of those 15% referrals, they only account for about 2% of our total phase 2 volumes. Heart failure patients are primarily being referred through an inpatient pathway. Heart failure patients, when they come to our centers, are staying for about 28 sessions on average. As you continue to look, we see that the breakdown of referring physicians shows that only 4 out of 9 of our providers or eligible providers are ordering cardiac rehab for these patients. There's no automatic referral process set up for this inpatient pathway. And you see that your current phase 2 program is operating at 65% of its potential capacity based on tangible resources like your staff, space, telemetry, etc. So a lot to digest here. We could probably spend the rest of the hour looking at every one of these variables and how we would inevitably set up an action plan to improve it. But the whole point of this case study is just to point out that when we pause and we look at some very basic data points, see what we actually observe based on our expectations, we can set up action plans that are really going to improve our services. They're going to improve it in terms of high quality. It's going to in terms of patient expectation. So in a couple of these, I think we look at the opportunities here. If we just think about if we were to focus on an automatic referral process, whether that be for our main primary care providers in network to refer these heart failure patients, or just in the inpatient setting where it's already lacking, you're going to have a powerful impact on some of these observed metrics. For example, you would expect to see an increase in total number of referrals, right? So you're casting a wider net. Therefore, you're going to have a better, whatever your conversions rates is, even if it does not change, your participation will go up. Your breakdown of the referral physicians, I think, is a big one. Automatic referral brings the capacity of maybe only 4 to 9 we're referring. Well, you have an automatic referral process now. It's a standing order. 9 out of 9 are going to refer. So you're really going to see big impacts on your operations. But imagine if you approach this case study based solely on your expectations. So if you just went off of your gut feeling that, oh, well, that we are going to have more referrals, so we better bring on more staff, we better get more equipment, we better, et cetera, et cetera. The expectations can be misleading because as we looked and we observed, we found that we're operating at only 65% of our capacity. So now we can really be making some intelligent decisions that really hit the bottom line on our total operations. So in the opportunities, in this particular case, automatic referral really stands to be one of our biggest impact metrics, especially, if we consider where we're operating already. So as we continue to look at this situation, this case study, we just want to think a little bit about the workflow because there are some standards out there on how we move through a process to observe these things. And like I said, and I certainly recognize that these metrics may be more alive for some centers than the others, but if we kind of make this expectation versus observed application, we need to think about what we do in a process, and we can move to the next slide, that really is efficient, right? So the first thing we have to do is identify who our stakeholders are. Who is going to be most impacted by these changes? Well, we have some primary care providers that are now going to be able to refer. We're going to have a heart failure clinic. We're going to be seeing a whole new demographic of patients. So here's some opportunity to reach out to those individuals. The estimates of our volumes, this is where that expectation, the expected versus the observed, is really going to be big. If we simply expect that volumes are going to increase and we don't know what our baselines are, how will we respond to that appropriately? So analyzing the impacts on our current operations in this scenario is an imperative. Even if we don't find ourselves to be formally trained in statistics, data gathering, etc., we've got to do it in order to respond to a changing climate. So think about here as we analyze those impacts on our operations, what are our tangibles? What are the resources that might be overburdened with large changes? So really, this is kind of about taking stock of the variables that you can't or cannot change just as much as there are the ones that you can. And as you analyze, that moves down the line. So you have to think about staffing, other resources, expendables, things that hit the bottom line, so to speak. And then determining the quality data metrics. So this is an opportunity, and as we've pointed out, data collection is a moving target. It's going to be changing all of the time. Well, if you have a new heart failure clinic, a new demographic of patients, you're going to have to determine new quality metrics. So new benchmarks are going to be set. As you set those baselines, you're going to be looking at year-to-year variables, month-to-month, making comparison, and really setting the validity of your operations going forward. And I think Professor Grace is going to talk to us a little bit about how we can monitor those things and track them.
Yeah, absolutely. So I wanted to start by talking a little bit about established ways to measure these quality metrics too. So if anyone is at an institution where they're participating in an ACC registry through NCDR, so the chest MI registry, chest pain MI, for example, they track referrals in there. You could exploit that and leverage that. If you're part of the AACDPR registry, for example, they track enrollment, participation, completions. You can really use that as well. You can also think about, as we've been talking about which providers are referring and what's kind of happening based on the logic behind how your automatic referral is set up in the system. And again, I think you're going to talk a little bit more about that next month. But you can see, which providers are referring. Do you need to make some adjustments in there as you can begin tracking this over time? And really, when we do that, we want to visualize that. So you could maybe use a dashboard or some kind of format like that to track your monthly numbers over time. So on the next slide, we talk about the importance of data visualization, or kind of graphically and visually representing the data that you have so that it's easier to interpret and so that you can share it with the other stakeholders and everyone kind of, gets on board about where you're going and how well you're doing and what needs to happen. So it really renders the data more easy to understand for all the parties involved. There are really quite a few different ways you can do this. I mentioned dashboards before. That might require, collaborating with your IT team, and maybe not all of you have that, but if you do have data analytics folks they're really handy at this and can whip something really lovely up for you. And the implementation guide has some really nice examples that you could work from there. But Matt here is now going to show us some examples of different charts, tables, graphs, timelines that you can use to see the impact of your workflow process changes over time.
Yeah, absolutely. Thank you. So I think on the point where I'm trying to really drive home is that don't let the data be too daunting, is recognize that there are formal, less formal, and probably a lot of technologies already at your fingertips to make your baselines attainable. Bring on visualization and really make some impact statements to your primary stakeholders to drive change. Professor Grace already pointed out some of those more formal opportunities, things like existing registries with the AACVPR registry being a great dashboard that's already set up. And I'm really a huge advocate of that. They've done a nice job making it easy to enter the data and pretty much foolproof. But maybe you don't have the financial stability or opportunity to invest in and participate in those registries. Well, there are still options. The first thing I would say is reach out to your service line, move up the chain, even talk to the primary cardiology clinics that are referring to your centers and see what quality initiatives or registries that they are already participating in. You will probably be surprised to find that many of these QI initiatives require them to refer to cardiac rehab or meet standards and metrics that you may not have been aware of. Some of these things may already be in place and be as easy as a conversation with those stakeholders and those referral providers going forward. But beyond that, if you have access to a workstation, whether it's Microsoft Excel or it's Google Office, there are a lot of tangible and easy to use tools that you can bring on. If I can make one plug for the use of Microsoft Excel, it is to enable one particular add-on, and it's on your screen, and that's your data analytics tool pack. You can Google how to add that, but it's very easy to add. It doesn't come standard on Excel, but this gives you the ability to break down your descriptive statistics, so your means, your medians, and do it all very quickly. I recognize that not all programs, actually I would say very few, probably have resources available for individuals to sit and do data all day. Many of us are out on the floor working off of those expectations and trying to respond. So we need to find efficient tools that allow us to see and visualize the data. It becomes very powerful. The next step for that is not only visualizing it ourselves so that we can respond and build action plans intelligently, but also so that we can motivate our staff and allow them to see where we're going and what the trends are. The third step for that is being able to take information back to our providers. So these graphs, these charts, they shouldn't just be a fancy or pretty way of putting your data. It's a means of concisely depicting what's happening in your space so you can very quickly put it in front of one of your medical directors, your providers, show them what's going on at a glance, and they can be able to help you make some plans going forward. The final piece I would point out in your tracking metrics, we've talked about a few, but a lot of the EMRs are set up to help you and probably already are tracking some of the data. Again, it's talking to your informatics teams, some of those specialists that work with that every day and asking them, challenging them to see what reports are available before you go and build something from the ground up. My saying with Microsoft Excel is you kind of have to pay to play, right? So I'll spend hours building a new spreadsheet before it gets to the point where I can plug the data and actually get something meaningful from it. Once it's built, it's very easy to use, but you might be surprised to find what's already out there with some of our existing EMRs, whether it's Meditech, Epic, or the like. So look at what your work queues offer you. See what revenue reports are out there, productivity reports. They can be very telling on what's going on in your spaces. And the final thing I would say about that, and I love that tip sheet. I think if there's one thing everybody takes away, it's the tip sheet we went through, is keep things simple. Make sure your data is simple to collect. So long as it's reliable and it's giving you some good information, you can work to refine those things later. So I'm going to show you a couple examples of some real life things that I have going on right now, just to kind of put this into perspective. So one initiative that our service line saw a deficiency in this year was our PAD referrals for our PADSET program. We had just started our PADSET program last year, and as I started looking at our referrals, I thought, goodness, these are really low volumes. So we went before our team, talked to our vascular surgeons and our cardiologists, interventional cardiologists, and I just brought this to them. And they actually set a co-management goal where they held themselves to making sure that they were participating in an automatic referral process. And so we just started tracking the data very simply. So this is a report that I give to them once a month. I drop it in an email. They're able to see at a glance if we're hitting the mark for the goal that we set for ourselves or not. So what I expected, right, was much higher than what I observed. So we made an action plan. So from there, you can see that this shows month-to-month data and trends. From the time that we started this initiative in February, I just very simply tracked the total number of individuals that were coming through. We looked at how many referrals we were getting, how many of those referrals enrolled, i.e. our conversion or participations, how many of those patients declined. You can see in this next column with those that referred out, that means how many people started going out of our system. We didn't start tracking that initially, so I only have one data point for June. That's some evidence to show you that you might start looking at things differently and asking different questions as you're observing your data. It was late in the game before we realized that was something we were interested in. And then finally, our total patient encounters. So as we broke this information down, it was really encouraging to go from February, March, April, and May and see that for referrals, enrollments, encounters, everything was trending up. So we were using this data in a way to kind of motivate us and see and observe if we were moving a trend in the appropriate way. At face value, you could look at things like our patients decline column, right? You don't want to see more patients declining to come to your centers. But we also used that as kind of an encouraging mark because that meant we were getting more referrals and therefore more people had the opportunity to say no. We at least knew we were casting a wide net with this data going forward. So let's move to the next slide. I'll just show you a final example of how you can use data in your centers, and it doesn't have to be fancy. So these are reports that we render every month in our centers where we look at net encounters in our phase 1 program, that's the graph in the left, and net encounters in our phase 2 program, that's the graph on the right. And why I show this to you is because what we found from months, even years of collecting this data is whenever I see a jump in phase 1 net encounters. So for example, September of 2020, you can see there we had a big boost in our phase 1 encounters. That meant more procedures through the door, more people on the floor. We know that there's going to be a downstream impact in our phase 2 operations. So we track that data, and as I see our trends going up in phase 1, I prepare and talk to our phase 2 staff to let them know that more referrals are going to be coming in. They should expect that within, a couple weeks that we're going to have more people enrolling. Classes are going to get busier, and there's kind of that slow rollout where we really see that evidence play. So this is just a way of showing you that really basic information can allow you to make some changes and prepare for change if you use the data regularly. But again, this report, I print this off of my EMR and I throw it into a spreadsheet and I visualize it. It takes me maybe 5-10 minutes at the end of the month. It's not too fancy, but it really has a big impact for our centers in particular. And I think that kind of takes it up for what I had to prepare. I think we're down to questions, Steve.
All right, thank you very much for the insights of Sherry and Matt. And now we're interested in your insights. So we'd really encourage each of you, and there's about 30 or so of you on the call today, which is fabulous. But we're really interested in the ideas that you've heard today that you found the most helpful for you as you think about beginning to or extending your uses of data as you prepare for automatic referral and care coordination. So if you can use the chat to enter any comments that one insight, or if you've got several, what is it from today's training that you're going to take away that you intend to use or change or do differently or better because of the suggestions from Sherry and Matt. Now, while you're doing that, I want to introduce Marion Harris Barter. Marion was just 6 or so months ago in exactly the same position that you are, participating in the first cohort of Take Heart and going through Module 4 and listening to discussion about data. And I want to turn it over to Marion for a few minutes here and just ask her to share, what she has done within her program to expand the use of their data to better support the needs of their patients. And I don't think that Marion's video is working right now, but Marion, I think your mic should be open, and we look forward to hearing your perspectives on today's module.
Thanks, Steve. Can you hear me okay? Okay. So there was so much in that presentation and so many things that I found as we were working to start or to grow on our data collection, what we needed to look at. But one thing I want to point out is I think it's so important to not only the person that, for instance, for me, I'm the one that's leading this team, but to also let your team understand the importance of data because it's really, they get so busy in their day-to-day activities and taking care of the patients, which is really what we want them to be doing. But if they're not understanding why you need to capture this data and how you're going to use that data to move forward, I think that then you don't have the buy-in of your team, and that's so important. So I really spent a lot of time talking to our team about why we need to start doing this. And then the other part of that is support them in entering data. I can't enter it at all for all our programs, so I need the staff to be able to do that too. And so they need the support. Some people, if I have my younger EPs or my younger nurses, they are much more tech savvy and can quickly enter the data, but some of my older nurses or EPs that have been around that aren't used to putting it in, I really needed to support them and make sure that they were entering it correctly. Because the other thing is that if the data is not put in correctly, it really does you not a whole lot of good. So we were able to identify some glitches early on and, work with the staff and the team to be able to make sure that they were entering it. The other thing we found is when we did get the automatic referral and we have Epic, it just opened up a world of reports for us. So I worked with our Epic team to be able to identify the data reports that I wanted. They send them to me monthly. We worked together to be able to do that, and that really did help us a lot. Something as far as I want to also mention is when you start to collect data and you're going to change your processes, as Matt said, make sure you're ready for that. We were, but it did take us some time to be able to process all those new referrals. The first couple of days that we went live with the automatic referral were a little crazy. We did anticipate it, but it took us a little time to be able to manage that and to work through that and get to the process where we're doing it all efficiently and we're getting those referrals in and followed and that type of thing. The other thing that I think is important is we collect data both in our inpatient and our outpatient department, but the importance of sharing that data with both, because it's all interconnected, and the continuity between one and the other. Obviously, our inpatient is there to help us feed into the phase 2 program, but if they're not seeing the results of what the changes are in the phase 2, they're going to be less likely to want to be able to help you with that data collection as well. I think, are there any questions yet, or anybody have anything that they want to ask me?
Yeah, thanks very much. And if you have questions, by all means, go ahead and enter those in the chat as well, and we will respond to them. Let me just turn for a second to Hisham Scali, the principal investigator for the Take Heart project. And Hisham, you're watching the second cohort go through this and, seeing some of the comments and questions that people have raised about data as they've moved further into the process. So are there any things that you'd want to really emphasize in your role as a cardiologist that looks at data for your program and also listens to participants talking about their program's data needs?
Thank you, Steve. And I want to again welcome the second cohort to this. I think one couple of key messages that were presented by Professor Grace here is it's never too early to get on this and preparing for collecting data. As we just heard, the EPIC is extremely resourceful in terms of the data that's out there. It's a matter of figuring out how to get it and how to present it. So I think number one is start early, start preparing the data, preparing what data you want and how you're gonna get it. Once you have it, and you're talking to your referring doctors and clinicians, whether they be surgeons, PAs, NPs, and so on, a picture or a graph that were like the ones that were shown in the presentation here can drive the message a long way. And so make sure to use those resources and those graphs and those messages in trying to drive up the referral rates. And the third point that I'd like to make is that once you get your data, once you start communicating with those, it never hurts to repeat that. So going back to referrals periodically is always helpful and gives a nice feedback to the people who are increasing their referrals based on this. And also it's a nice reminder to people who have not yet changed their practices.
All right, thanks very much. And by all means, enter questions into the chat. I know it takes a few minutes to do that. And while you're doing that, let me just mention a couple of additional things looking forward a bit. You should have a team set up at this point. You may still be adding some members, but your core team should already exist. So working with them to figure out how to make changes, that's the next step. But then we also want to encourage you to take a look at the Module 4 implementation guide that focuses on data. And this is the first page of the guide, which you can download off of the Take Heart website. And you see the categories that it has in there. Just define some terms that were mentioned in the presentations today, and then basically talks you through the process. You may look at this and a couple of the steps you've already done, so you'll be able to check those off and move on to the next one. So whether you're really very new to the use of data or really a quite sophisticated user already, there's some good insights in that. Just to show you a couple of things in the implementation guide, as Matt mentioned, there are a number of dashboards in the implementation guide that just give you an additional sense for the kinds of things that you might want to be tracking, like referrals that come from outside of your system or inside of your system. How many people opted out over time if you're really working with the physicians to reduce the number of patients that are opted out for not necessarily great reasons. So those are a couple. Some others look at additional things like how long it takes from the referral to attendance. I know for a lot of programs that's gone up because of COVID. So there's a lot of information, and then in response to a question, where do we find all the ICD-10 codes to identify who's eligible? Those are included in this implementation guide, and they were also included in the the data exercise that we shared with you already. So those are really important, and we include them in a couple of places. So just looking ahead now, in terms of things coming up, we want to encourage you to continue working with your teams to explore the implementation guide and then to participate in one of the upcoming Peer Action Group meetings. You've gotten the information on how to register for one or either of those that are occurring next week. So the times for those Peer Action Groups next week, you can participate on Tuesday, Wednesday, or Thursday in one of those groups, and we really encourage you to do that. And then coming up next month is Module 5, Building and Implementing a Successful Automatic Referral System. You need data for it, but the automatic referral system is really critical, and Module 5 will talk you through the first steps in creating an automatic referral system. And then we'll give you a chance to get started on that, and then we'll give you more guidance on automatic referral in Module 7. Of course, if you ever want to peek ahead, you can certainly do that, all of the modules are online if you want to look at those modules even before we get to them. We would like you to respond to the feedback questions. WebEx has changed the formatting of these. They used to pop up after you closed out. But if you could just take a second and fill out those questions before you disconnect this afternoon, we'd really appreciate the feedback. We want to make these events as useful for you all as possible. So having said that, we want to thank you for your participation. Thanks for filling out those feedback questions. We look forward to talking with you in an upcoming peer action group or at Module 5 next month. Thanks, and have an excellent rest of your day.